All right, good afternoon, everybody. It is 4 o'clock here on Wednesday, April the 6th, correct? And
It's
so
the
we
7th.
are the 7th, my apologies, the 6th. Thank you, Aaron. My name is Ahmad Brahmi. I'm a division manager here with the Fresno County Department of Behavioral Health. Aaron Reinbold, our MHSA coordinator, who you just heard, is also on this live stream to assist with this public hearing. We're holding a public hearing this afternoon for 2 of Fresno County's proposed innovation plans. We've completed a 30-day process on these, and so today is our public hearing so that we can wrap up this project or wrap up the process necessary for us to submit these plans to the Mental Health Services Act Oversight and Accountability Commission for approval. I do just want to note that both these plans have probably gone through a more rigorous public input opportunity than some of our other plans, just because of the timing of it. These plans have been in the 3 follow-up sessions we did at the conclusion of our MHSA 3-year planning. They were part of the 3 different MHSA 3-year plan public hearings and forums. They were shared with our board. They're in our 3-year plan that is slated to go to the board next week, I believe, or later on this month. We again had, like I said, a 30-day public hearing specifically for these plans that just completed this week. These plans have been shared with various outlets, including through our Cultural Humility Committee, as well as with our Suicide Prevention Collaborative. So overall, I mean, these 2 programs have gone through, I would say, numerous public hearings and inputs and opportunities from all of our stakeholders, those being our boards, our partners in those various collaboratives, community members, et cetera. So with that said, I will go ahead and jump us into the PowerPoint presentation. So Aaron, if you could advance to the next slide, which should be there you go, the public hearing process slide. Perfect. So just the public hearing process so that you guys are aware of what that we touched on. We're required to have for any of our MHSA plans, public hearings, anytime we do a plan itself, or have changes or modifications to a plan, adapting a plan or putting forth a new plan, we do go through the public hearing process, which is the plan has to be posted and available to the public for 30 days, allow opportunities for them to provide input and feedback, and then we go through the process. So this is with regards to 2 innovation plans. And what I'm going to be doing is covering 1 innovation plan first, which is our Suicide Prevention Follow-up Call program. And then I'll go into the California Reducing Disparities Project Evolutions, which will be the second process. So innovation is one of the 5 parts of the Mental Health Services Act. Innovations are basically one-time funding that is really geared to allow us to either pilot a project, conduct some research, learning adaptations to projects. Really shouldn't be utilized for seed money for a new startup, but really giving us that opportunity to test something out. If it doesn't work, make the adjustments, adaptations, and really contribute not just to local learning, but statewide system learning. Innovation plans are to be community driven, so it can't be, for example, I have a dream at night, and then I go, it'd be great is if we do a B and C, and then turn that into an innovation program. Innovation programs are really driven by our community input, and these 2 were actually, we'll get into a little more, did come really from our community partners and stakeholders. Innovation projects do require to go before the Mental Health Services Oversight Accountability Commission and to get approval for those plans to go through for us to be able to expend those revenues, to encumber those revenues, and to do the projects. And then all of the innovation projects are required to have an evaluation component that ensures that the learning, the evaluation, the assessment of the projects happen. For us, we've been traditionally utilizing even a 3rd-party evaluator. 1, in part, that it provides a level of objectivity, and then B, we don't always have the capacity or the expertise to do those ourselves. So in Fresno, we've always brought on external evaluators to assist us with the evaluation of those components. So if we go to the next slide, Aaron. So the first program I'm going to talk about here and discuss is the Suicide Prevention Follow-up Call program. So if you were on our Suicide Prevention Collaborative meeting last Friday, which is an open meeting for everyone, And you actually can find it on our YouTube channel because that one was streamed as well. As we did a more deep dive into specifically what a suicide prevention program is, but it is an evidence-based model that really looks to engage individuals after a suicide-related incident, whether that is a talk down, an active rescue, somebody who had called the hotline for active ideation, or someone who's maybe attempted and as a result has been hospitalized or received some types of crisis services specific to their suicide ideation. What the suicide prevention follow-up call program does is really that. I mean, it does the follow-up after the incident. It reaches out and it follows up with the individuals to find out, well, not to find out, but to ensure that they were connected to services post-discharge or, after the call had been made. That follow-up itself is really a key component. Just having that investment and involvement with an individual following up after their crisis has been shown to be really effective in reducing risk for suicide, and also allows for the reassessment of the individual to make sure that they're still not at risk. If they are, do we need to change their plan? Do we need to connect them to more resources? And it has been shown to be a really effective way to increase access and linkage for those individuals. As far as what is innovative about it, because you're saying, well, this is an evidence-based program, it absolutely is. It's not a program that's been used here in Fresno. It's not a program in that model that's widely used around the state, but we wanted to go something different. We wanted to look at, could this help increase timely access to care for individuals who experience suicidal ideation or some type of a crisis, with the specifics of being able to reduce the wait times, the delays from, when they call or they're seen in a hospital to where they get engaged in services. Making sure that we're utilizing that follow-up to assess for risk to reduce suicides. But really ours, what we wanted to do is add a component, or really, I don't want to say add, we'll add and maybe revise this model, which is when we have the persons on the phone on that follow-up call program, to utilize that opportunity for engagement to really find out more about what is going on with that individual, or what was going on with that individual, either emotionally or what was going on environmentally, socially, that maybe brought them to that point, to that ideation, to where they were either hospitalized or even, what was the impetus for them calling the lifeline. And so this gives us a chance where normally you're not able to do that when someone's in crisis. You are trying to assist them and definitely, secure life and provide those protections. The follow-up call program, we think, included into this model, would allow people to do that follow-up, train counselors to find out, was there something that was going on campus? Was there something going on in the community? Was there something going on online? What was it that was really contributing? And that would potentially would be able to use to inform and improve our prevention efforts. Right now, a lot of times our prevention efforts are well after the fact. We do have to wait months for attempts and completed suicides and things of that sort to be able to get an idea of what are the trends and where we should be focusing our attention. And we believe by adapting the follow-up call program to do some of that engagement, we can really find out within a matter of days and weeks, what's going on and be able to change. And really, when it comes down to things like contagion effects and clusters, that we may be able to intervene much more quickly because we'll know what's going on with that population, with that group, with that campus, with that community. So those are really the things that we're looking to do to make it innovation, to make it innovative, to provide some new learning, to really see, could this model be a great way for us, but other counties in the future and lifelines to help with their prevention efforts and how they target folks. We're going to go to the next slide, Aaron. All right, so as we had mentioned before, the community stakeholder process is really important for these innovation plans. And I wanted to reiterate for these, but this is not a new plan. This was actually something that was identified in Fresno suicide prevention plan, one that was developed several years ago. And we're very proud that we're one of a handful of counties that had plan and is working on it. And that plan's really been a guide forward. And about 2 years ago, we went through a process where we had projects and ideas once we got the LOSS team established, projects and ideas that the committee, the Suicide Prevention Collaborative, which is made up of 60, 70 different entities, 100 plus different individuals, represent cross sectors as far as what were some of the next programs or models that wanted to explore. And the next one in line was a suicide follow-up call program. This was identified. It was in our 3-year plan. We were exploring utilizing this as a um, as a what is the word I'm looking for? A PEI plan. But then some of the events that happened during COVID and really at the end of the summer, fall, start of the school year, which we were seeing a sudden increase in crisis calls. We've seen the call volume expand exponentially during the time of COVID. Number of active rescues, complexity of calls, things like that have gone on. So we definitely felt there was a need for the follow-up call program, but based on a couple of incidences where we were able to get a heads up that some populations were experiencing, some crisis, we were able to gather the collaborative, have some quick conversations, develop a strategy, get the information out, and really be a, respond to, an environmental factor, maybe a social factor that was happening. We were able to respond to it, almost immediately within several hours. And that made a lot of us think of well, what do we do in situations like that in the future? And even with that, we still didn't have information directly from the individuals who were experiencing the crisis. And so the thought was like, well, could we use this follow-up call program we're planning on to really be able to do that follow-up, get that information, find out what needs to be done? And so that's really where this plan went from where it was already going to be in the MHSA 3 plan to really be considered as an innovation project where we would try to utilize it for something broader than it was originally intended for. And you'll see on the slide, we went through the follow-up sessions, public hearing, 30-day comment, public comment cards. I don't believe to date, Aaron, we've gotten any public comment cards on this particular program. As I mentioned, we went over last Friday with the Suicide Prevention Collaborative. It definitely has a lot of broad range support. And when we've mentioned our intent for this program with other suicide prevention type work groups around the state within education sectors, it's people have been really excited to see, if what Fresno is proposing could work and could be something that they can copy and replicate. So thank you for that. We're going to go to the next project. So just for everyone who's viewing, watching, we're going to do a shift. This is going to be the second innovation project we're presenting. When I'm done with both projects, we will then have, if there's any questions or discussions for those programs there. So if you're just taking notes, this is a second program right here. And this is the California Reducing Disparities Projects Evolution. So real quickly, the CRDPs, as they're called, the California Reducing Disparities Projects, are 35 statewide pilots looking at community-defined practices within 5 populations. Those populations being African American, Latino, Pacific, Asian and Pacific Islander, Native American, and LGBTQ, and looking at what are some potential community-defined practices and programming that could be responsive in meeting the mental health needs of our underserved or inappropriately served populations, primarily because evidence-based programs are not always applicable across all populations. So they're usually very specific and very effective with, I shouldn't say very, are effective with the population that it was tested on. So you may have an evidence-based program, but it doesn't mean that it's going to work for all populations, especially when you start factoring things like language, culture, things of that sort. So this project was a statewide initiative that did use MHSA money, but it was state MHSA money, and it was done through the California Department of Public Health, not the Department of Healthcare Services. Was not done with county MHSA funds. So in some instances, these programs were operating completely outside of the umbrella or scope of the system of care. The reports, the funding, the engagement and encounter was all done with the State Department of Public Health and not with the local jurisdictions. And so a lot of those programs have been doing some great work, but they haven't been integrated into the system of care. And so in Fresno, we do have 3 CRDPs. The Sweet Potato Project, operated by the West Fresno Family Resource Center, and that one is actually utilizing entrepreneurship and ag to really do prevention activity work with African American youth. The Atención en Prácticas is a mental health approach, treatment, prevention, some intervention potentially, but more prevention. That has been targeted and specifically developed for working with Latino youth. And then Among Helping Hands is a population-specific prevention program that's primarily working with our older adult Hmong population that also experience some cultural and language barriers to regular care. And so these are three programs that exist as part of the CRDP in Fresno. And with this innovation plan, Fresno is looking to continue to fund these programs for another 3 years so that we can look at what are things that we could do in terms of an adaptation to these programs that would allow them to align better with, for example, PEI funding, prevention early intervention funding, that would be done in collaboration with those providers as well as the populations they serve. So really what we're looking at the innovation is not so much the county coming and saying you need to do A, B, and C, but really developing these community partnerships and almost a participatory action research type model of working with the providers and working with the community and say, hey, what are some things that we could do that you would be open to, that we could try to adapt or make a change to the program that would allow it to align with one of the PEI 6 funding strategies, and at the same time be done in a way that does not change the core and the core of the program or what actually made it community defined and culturally responsive. So some of the learnings you'll see on there, I've kind of touched on. Really, we want to look at what are the adaptations specifically that can be done. We want to look at identifying what is the role of the community in that adaptation process, and primarily so that we could look at how that information could then be shared potentially with other CRDPs, with other counties who are looking at developing maybe their own adaptations, or how they are maybe looking at bringing those CRDPs into alignment or into just their system of care. And then we want to be able to look at, does a program work still as effectively with that adaptation? There's always a risk that, if you change it, does that impact us? So we're going to be evaluating those as well. And then lastly, just providing like we said, a guideline for just the other 32 CRDPs in terms of ways that they may be able to, like we said, become part of their county system of care, because right now they're primarily working as public health department projects and not necessarily behavioral health projects. Go ahead and go to the next slide, Karen. All right, we're almost done here, folks. So the Crdp Evolutions, a couple of things for people to know. We've been working for almost a year and a half now with our 3 local CRDP projects, trying to explore ways that we could collaborate and bring those programs on board. We've done everything from meeting with the programs. We have reviewed the evaluations that they've gone through. As you see, 2 of our 3 current CRDPs actually hosted the MHSA 3-year community planning process. We did do a lot of discussion. We did ask, the community for input about our underserved or inappropriately served populations, and was there a need or a desire for culturally specific programming or services? And really, outside of these CRDPs, there wasn't a lot. The call was for us to really utilize these CRDPs and take them to the next level, integrating them into our system of care, but not a lot of others. And so these really became some of our culturally specific approaches we're hoping to be able to bring into our system of care. It is in our 3-year plan. We've discussed these in a number of other forums as well. And then Fresno and the team from Fresno was actually involved with the California Pan-Ethnic Health Network process, which was working with as a steering committee with a number of stakeholders and other CRDPs and other counties. And we were one of, I think, 3 counties that were involved in that process to try to inform and come up with a strategy. And the paper that CPAN has a draft of that's posted actually makes a reference to the idea that Fresno pitched at that time, which was, could we fund some of these CRDP work through innovation projects if we're trying to look at making adaptations or changes to these CRDPs? So, and a couple of the people have referred to it as the Fresno model. I don't know if it's necessarily a model, it's just a way that we thought that we wanted to really support our CRDPs, but really understand and better do a better job at bringing them into our overall system of care in a way that is still responsive to the community and to the populations they're serving. So this plan has also been out for 30 days, which is now ended. We're doing the 30-day public comment. If I recall, Aaron, I think the comments or questions we got were really more related to a facet of the program itself and not to the CRDP and the work that it has been doing aside from the county, and not so much to our plan. So we weren't really able to answer, I think, there was a couple of details with regards to school locations or things like that. But those are things we can definitely get information on. Yeah. All right, so if we can jump to the next slide, and we're almost done here, folks. Thank you for staying with us. And so the budgets, that's a really important thing to consider is the budgets for projects. As I had mentioned, innovation projects, if you're using them as seed money and you go big with it, the challenge you run into is if the program proves to be effective, if it proves to be something that you want to continue, you have to find other funding after the end of the innovation funding to sustain it. And so when they're really robust programs and there's a lot of money on the startup and a lot of money on the project itself, it does make them difficult to be sustainable. We have decided to still go big with a lot of our innovation projects, but we've gone bigger because we're really looking at also the evaluation components and really wanting to understand the programs and sustainability and seeing the innovation projects we're proposing. Are they working? Are they worth continuing? Are they going to be a good investment? And so we go big on the evaluation component of it, but overall on the program, we have tried to focus as much as possible on also sustainability. So not having programs that probably could not be sustained in the future. And for that reason, you'll see the suicide call program is actually $1 million over 3 years. The cost, I think itself for, there was about $200,000 of that that $1 million is actually for the innovation. And where we do have a national expert on suicidology, as well as has done a lot of work in literature review and familiar with the work with the follow-up program locally, who we have identified to assist us with that. And then the remainder of the program the money is going to be utilized to fund the Central Valley Suicide Prevention Lifeline, who's our partner on this project. And their team over there had really identified I would say a great budget that allows them to meet the needs for this project, but was not heavy with a lot of overhead. Something that we hope and believe that, at the end of this project will allow us to continue and sustain that follow-up call program. So that's a heads up on that one. The Crdp Evolutions is $2.4 million over 3 years. We also included in the evaluation as well as some of the community planning process, because we felt that that's going to be really important to not just set up the community plan process, but be able to understand and track that component, as well as, what is the adaptation? Does the adaptation work? What impact does it have? So we did send that area. And again, we focused on sustainability. And what we did is actually funded these three, we're planning to fund these three programs at their current funding level. So we did not grow these programs. We're not going to be expanding them. We're not going to be adding to them. We're basically keeping them at the funding level that they're at today. So the services will continue while we also work at the same time to try to identify that adaptation and get the community and the provider input into things that we may be able to do to help it better align with a specific funding source. And with that said, we'll go to the last slide, Aaron, which I think will allow us to see if there's any input. Wow, that's pretty quick. Okay, this is good. We did close public comment. We are looking to finalize the plans after today's call and get those submitted to the OAC as soon as possible, ideally by the end of this week. The OAC will then need time to take those plans, do their brief for it, get it to the commissioners, do whatever else needs to be done just in preparing for the hearing, which will be later this month. The commission hearing is going to be, those will be public. The meeting is set to start at 9 o'clock. The agenda is not up yet, or at least it was not as of last week when we were developing this PowerPoint. But if you go to the MHOAC's website, under news and events, they'll have the commission meeting hearing and information regarding the April 22nd should be, the full agenda should be available on there, which will provide information and instructions for any members of the public, any stakeholders that wish to provide public comment. Because of the virtual, people do have to sign up for it ahead of time, and so that they can schedule and line people up in the queue for the opportunity to provide or share some public comment. But there will be an opportunity for that as well. And then once those plans are approved, like I said, these plans are in a 3-year plan that's going. Sorry, I have a helicopter flying over me. MHSA 3-year plan will be going to board this month, so that'll be finalized. And once the MHOAC approves these two innovation plans, we'll be able to add those to our annual update. And as we get ready for the contracting process, then we'll be taking those also to the Board of Supervisors. I want to say there's also going to be some additional just information, I think, has been requested by our Behavioral Health Board Chair for the meeting later this month. It's been a minute since I looked at that, so I have to double check, but there's ample opportunities for people to have gotten info on this. You'll be able to watch, this will remain on our Facebook and YouTube, so you can go back and look at it. If you just check the OAC website, like I said, they should have the agendas soon, and the full agenda will provide the information should anyone want to provide any public comment or any support for this project. They'll be able to do that there. Do you have any questions that you're aware of, Aaron?
I am sorry. Can you check? I believe we were sending the questions to your. Any questions will be sent to your Teams messaging since my screen is being shared.
Good idea. Hold on one second. Let me go to Teams. I think Lisa said we've got a few people watching, so thank you for the people tuning in, but I don't think we've got any specific questions yet. No, Lisa said no questions, and that was as of 4:26. So that was about a minute, less than a minute ago. So we'll give it about a minute, and if we have no other questions at that point, we will hop off. Like I said, we've talked about this plan now. I would say for the past 6 months in a number of different forums and in official capacities for the department, from the feedback sessions, our MHSA 3-year plan, a public comment period with our board, with the various work groups and stakeholders, like I said. So I think it's been well shared, and people are pretty well aware of it, and that might be the right reason why we don't have a lot of questions. And I also want to thank our stakeholders out there who have provided letters of support that will be included with this plan for both the suicide prevention as well as community members who've lended their support also to our Crdp Evolutions project. So we're really grateful for that as well. But I have to switch back, sorry guys, from the Teams back to the video and make sure that we've got that. If you do have any questions that come up after this, obviously the public comment period has ended, but if you have general questions about the program, want to know the status, what's going on with the program, you can always email us. The comments may not go into the final plan, but as stakeholders, we definitely welcome your comments always, and inquiries and questions. So you can always do that by sending an email to mhsa@fresnocountyca.gov. You'll see the email right there on the screen. And that could be with any MHSA question that you may have, like I said, whether it's these innovation plans or anything else. And we'll be more than happy to try to assist in responding to those the best we can. I don't see any other questions on here. And I don't think Lisa has anything else that's come up on the other ones. So with that said, we're just gonna remind people, if they have questions, by all means, you can always email us. Other than that, we thank you all for your time, your interest in this. We're excited to get this done, get it into the OAC's hand, and we look forward to the April 22nd commission hearing, where we can get these approved and really do some innovative, creative, just new ways of addressing and improving our mental health system here in Fresno with these innovation plans. So very excited. Thank you all for your support. And hopefully we will hear you, or you guys will be able to participate on the April 22nd hearing. Thanks.